Hello everyone, welcome to today's webinar. Uh, Today I decided to go back to the basics and talk about basic somatosensory evoked potential because we do monitoring, and when we get busy, there are some basic very important things that we start forgetting. And if you have a very good basic understanding of modality, then it's very easy to build up on that and perform in multiple different type of surgical procedure and more complicated procedure. But so I'm just going to go start my presentation now. So sensory evoked potential is used during high-risk surgical procedure, and it is typically utilized for protection of ascending sensory pathway, which is a dorsal column pathway. So there are 5 basic sensory function that we need to know, which are covered by these dorsal column. Number 1 is stereognosis. Stereognosis is a sensory function which is sent through the joint and receptors. If you hold an object without looking at it, you can tell the structure of object. It is round, square, oval, whatever shape. So the shape of telling about the shape of the object without looking at it is known as stereognosis. The second function is known as proprioception. Proprioception is a sensory function which is transmitted to the dorsal column, which tells about where is your body parts in time and space. So if you're looking at screen right now, you can tell, where is your foot or hand without looking. So that's a sensory function which is transmitted in the dorsal column. Another one is tactile discrimination. Tactile discrimination is touching on, or it's also known as 2-point discrimination. 2-point discrimination is if somebody is touching on your skin at 2 different points, you can tell that the pinprick, or if it's a pinprick or a touch, there are 2 distinct touches. If you move those 2 points together, at one point you lose that capability, and you cannot differentiate between the 2 inputs. And the reason is the sensory function is transmitted to a dermatome. A dermatome is a patch of the skin which take the signal to the brain. So when somebody is touching on 2 different dermatomes, you can tell the difference. But if the dermatomes, if you touch in the same dermatome, it transmitted as a single signal. So you cannot, but that's a normal function. But if the dorsal column is affected, is damaged, then that function disappears, and the patient cannot tell. The number 4 is vibration sensation. So as vibration sensation, vibration on the skin, that also transmitted to the dorsal column. And the last one is the weight discrimination. Weight discrimination is a sensory function where you can tell the weight on an object without looking at it. So you can hold an object and you can tell it's a heavy or light. These are very important, and these are the first I'm putting on the first slide, because if somebody asks you, you lose your right hand SSEP or right foot SSEP or left hand SSEP, and a surgeon asks you what sensory function will be affected, or surgeon, if the patient wakes up, he or she will have any deficit, which sensory function you are monitoring. So those sensory function you can tell and keep on your fingertips is stereognosis, proprioception, 2-point discrimination, tactile discrimination, vibration sensation, and weight discrimination. So the benefit of SSEP is, again, it's used interpolated to monitor the blood flow of the brain. So there's direct benefit and indirect. So they're direct. Indirectly, we are monitoring blood flow to the brain stem, spinal cord, or peripheral nerve. So if there's a decrease in the blood flow, or there's ischemia to the brain, or brainstem or spinal cord or peripheral nerve, or peripheral signal will be affected, or brainstem signal will be affected, or brain signal will be affected. So we can tell indirectly there's ischemia to the brain by measuring the blood flow through the somatosensory evoked potential. The direct testing is direct test of functional and structural integrity of the spinal cord or the nerve root or peripheral nerve or somatosensory cortex. So if there's a damage to the structure or function, and in fact the function of that structure, we can do a direct assessment through somatosensory evoked potential. So utilization of SSEP has been reported in literature as early as 60s, and SSEP is most widely used monitoring modality to assess the status of somatosensory pathway during various surgical procedures. The function of SSEP is to evaluate the integrity of sensory system, as mentioned previous slide, brain. So for brain, it's used for central sulcus localization, for monitoring aneurysm, for arteriovascular malformation, AVMs, for carotid artery repairs or embolization surgeries, for the brainstem, fourth ventricle tumors, CPA tumors, brainstem aneurysms, any surgery on the brainstem, we can do a somatosensory evoked potential and give a direct information about the blood flow and structure of the brainstem. Spinal cord, for spinal cord surgery, all the deformities, trauma, tumors, aortic, spinal implant, all this implants. So everything related to spinal cord can be assessed by using SSEP. Also for peripheral nerves. So if we are doing nerve grafting, neurolysis, or peripheral nerve tumor resection, we can utilize the somatosensory focus to that. So I'm going to talk about the pathways, then generators, stimulation, recording site, parameter for stimulation and recording, more signal morphology, anesthesia, and the montages. And we're going to talk about some data at the end. So first of all, the anatomy of somatosensory pathway. The Upper SSEP pathway are time-locked dorsal column mediated medial lemniscus ascending pathway, which are in response to peripheral nerve stimulation. So when patient is under anesthesia, we can test all those sensory functions by causing an evoked response by stimulating by electrical stimulation and recording. So somatosensory pathway have three first neurons and they have multiple neurons. So the first order neuron is the first neurons from the dermatome to the first recording site, or it also from the stimulation site to the first recording site. It carries the signal from stimulation site and it enters the spinal cord via dorsal root entry zone, and it travels up in the dorsal column and it forms fasciculus cuneatus. Fasciculus means columns. Cuneatus is referred to the upper pathway. So fasciculus cuneatus is the pathway in the spinal cord. The second order neuron is the neuron start after that. So it makes a synapse in nucleus cuneatus. So every neuron has three major parts. One is known as axon, cell body, and dendrite. So the neurons, they travel in bundles, so they don't travel alone. And the bunch of the cell bodies, they are tied together, they are placed together in the nervous system. And if the nuclei are outside the central nervous system, they are known as ganglia. And if the nuclei are inside, or the cell bodies are inside the central nervous system, they are known as nuclei. So the dorsal root ganglia is the collection of the cell body of the first order neurons, but there's no synapse. So it's just a cell body which is taking the signal for the dendrite from stimulation side, and it goes, and when it crosses the dorsal root ganglia, it becomes the axon, and it makes a synapse with the cell body of the second order neuron, which is a nucleus cuneatus. Nucleus cuneatus is the cell body of the second order neuron, and it crosses over in lower medulla, and it decussates on the opposite side, and that decussation is known as medial lemniscus. And the third order neurons start from the thalamus. So the thalamus is the cell body of the third order neuron. So it's a collection of cell body of third order neuron, and it makes a synapse with the second order neurons, and that neuron travels up the somatosensory cortex and terminate in the post-central gyrus, also known as somatosensory gyrus. So these are the three first neurons from stimulation side to the first cortical recording. But if you do median nerve stimulation in a awake patient, you get a response up to 312 milliseconds. So So it's not up to 20 milliseconds. So you have 20 milliseconds, 30, 35, 40, 45, and you keep getting responses by multiple synapses in the cortical neurons up to 312. But because of anesthesia, we don't see those. Another important point is the blood supply for all those signals. So the blood supply of the cortical signals, third order neurons for median nerve is through the middle cerebral artery, which is a branch of internal carotid artery, or also known as ICA. Just like upper SSEP, lower SSEP has also three order neurons. You have first order neurons, you have second order neurons, and you have a third order neuron. So the first order neurons carries the signal from the stimulation side, and it goes enter the dorsal root ganglia into the spinal cord and dorsal column, and it makes and that is known as fasciculus gracilis. It travels up in the dorsal column and make a synapse in nucleus gracilis. Nucleus gracilis is the cell body of the second order neuron, and then it crosses over through the medial lemniscus. Medial lemniscus is crossover and makes a synapse with the third order of neurons. And the third order neurons for the lower SSEP start from thalamus, and it makes a synapse in somatosensory cortex and postventral gyrus. So the blood supply for the lower SSEP is through anterior cerebral artery or anterior communicating artery, which are branches of internal carotid artery. Another important point to remember is spinothalamic pathway are the second pathway, sensory pathway. So we have dorsal column pathway and spinothalamic pathway that terminate in thalamus. They carry pain and temperature, and those two sensory signals, the pain and temperature, they are not covered by somatosensory monitoring. They are not traveling in the somatosensory pathway. So if you have good SSEP, that does not mean that patient will have intact pain and temperature post-operative, because we are not monitoring and we cannot monitor right now those two pathways, and we are just doing dorsal column pathway. So if the surgery is going to start, so let's go into the OR surgery start. So the most important thing for doing SSP is measuring the head according to 10-20 system. So I always recommend and always tell the same thing again. Go to the pre-op. If you go to the pre-op and you have access to the patient, when you take the consent, you talk to the patient, measure the head. And measuring the head is the most important part of getting a good signals for SSEP and for motor evoked potential. Once you measure the head, then you check the protocols, go to the computer, check your protocol, you have everything is intact, and you are familiar with all the protocol for setup and recording. The third one is setting the patient with stimulation and recordings electrode and record the baseline before the incision. And the last one is document the baselines and report the data to the surgeon through the surgery. So the fact I want to mention is somatosensory potential is a recording typically on the surface of the skin of a volume conducted bioelectric event originating in the ascending pathway of the nervous system, and each major deflection correspond to activity in the discrete site or portion of the pathway. So it's a bioelectric event which is transmitted on the surface of the skin as well, and that's why we have to get rid of that extra current spread through using the ground electrode. And bigger the ground electrode use, you'll have a less problem with the stimulation artifact and noise in these type of cases. So in order to do a good recording site, it's very important to remember the pathway. So always try to draw the pathway and memorize those. So the understanding of pathway is detailed before you go, because that will tell you where is the problem. So if you know the problem, you can have alternative recording side, or you can have an alternative stimulation side. But if you use an electrode for alternative recording or stimulation side, you should have a good explanation for that. You cannot just go and put that randomly. So if you're looking at this picture, so if you're stimulating the median nerve or ulnar nerve in the hand, it enters the dorsal root. The nerve has ventral root and dorsal root. So the signal is traveling to the dorsal root and it enters the spinal cord and it's going up in the dorsal column and makes synapse in nucleus gracilis, and then it crosses over to medial lemniscus and makes synapse in thalamus and then somatosensory cortex, and same thing for the lower SSEP. It is known as dorsal column medial lemniscus pathway because dorsal column carries the signal up until the nucleus cuneatus and nucleus gracilis in the lower medulla, and then the medial lemniscus is the crossover pathway which take the signal to thalamus and to the somatosensory cortex. So again, for dorsal column, very important to remember the stimulation sites for all the nerves: the first order neuron, the second order neuron, and the third order neuron. Another important is I'll like to stress is drawing and memorizing the brachial plexus and lumbosacral plexus, because brachial plexus, all the nerves which are covered, we are stimulating or recording in the upper extremity. You need to know the anatomy, and looking at the picture is a little bit difficult, but if you look at the picture and then draw that few times, that will tell you why we do different type of monitoring. So if you, for most of the surgeries, the ulnar nerve and median nerve are monitored in upper extremity. So if you look at the left side of the picture, you have the roots. We have roots. The brachial plexus have multiple. The parts are roots, then trunks, then divisions, cords, and nerves. So if you look at the left side in the roots, you have C5, C6, C7, C8, and T1. Those are the roots for the. So upper C5 and C6, those two roots combine and they form an upper trunk. The C8 and T1, those two roots combine and they form the lower trunk, and C7 remains a single and it forms the middle trunk. So we have 5 roots and they form 3 trunks: upper, middle, and lower. So each trunks divide into 2 divisions, and each division is known as anterior division and posterior division. So upper trunk has anterior and posterior. The posterior division of upper trunk, middle trunk, and lower trunk, they combine and form the posterior cord. So if you look at the under the cords in the middle, that's a posterior cord, and it's formed by 3 posterior branches of upper, middle, and lower trunk. The upper and lower anterior division of the upper and lower middle trunks, they combine and they form the lateral cord. So the lateral cord is most outside and is on the shoulder under the deltoid muscle, near close to the deltoid muscle. And the lower trunk, the anterior divisions of the lower trunk forms the lower cord, medial cord. So you have lateral cord, posterior cord, and medial cord. So medial cord is the most medial to the body, and lateral cord is most lateral, and posterior is behind the two. From these cords, we get the nerves, and the most common nerves we get from posterior cord is radial and axillary nerves. The medial cord gives us ulnar nerve, and the lateral cord gives musculocutaneous nerve. The lateral and medial cord, they combine, they give a branch, a root to form a median nerve. So if you look at ulnar nerve is formed by the medial cord. Medial cord is formed by the anterior division of lower trunk, which coming from C8 and T1. So ulnar nerve has C8 and T1 roots, compared to median nerve, which is formed by lateral and medial cords, which are formed by the three anterior divisions of all 3 trunks. So that has C5, C6, C7, C8 too. Musculocutaneous is coming from the lateral cord, from the anterior divisions from the upper trunk, which is C5 and C6. So you can go back, and why this important? So now if you look at brachial plexus like this, and then you say, okay, the C6 and the surgery on C6 vertebral body, the median nerve will have roots going above 2 roots, C5 and C6, and C3 roots below. The ulnar nerve, everything will be below. So I have a surgery from C5 to T1. You cannot monitor the ulnar nerve because one of the reasons we do upper SSEP is to have a control above the site of surgery, but also for positioning. And many times people, you are asking why the ulnar nerve is more, which one is more sensitive, and why which nerve is more sensitive. So ulnar nerve is more sensitive because ulnar nerve is coming from only two roots. So if there's a, so it's two roots. So if there's pressure on one root, you lose 50% of the signal. And if you extend the arm, the ulnar nerve is coming from the medial cord, which is close to the spinal cord. So it will be stretched away from the spinal cord and have more effect. So medial nerve has less effect than the ulnar nerve. So anything below T1 to sacrum, ulnar nerve should be used for positioning, and everything above C1 to C4, ulnar nerve should be positioning, and at C5, C4 to T1 should be using median nerve and ulnar nerve for the surgical procedure. Same looking at the lumbosacral plexus. Lumbosacral plexus, they don't have root trunk divisions. They have roots and anterior and posterior division. Each root divide anterior and posterior division. In this picture, we don't see L1, L2, but starting from L1, L2, the L1, L2 roots, they combine and they form genitofemoral nerve. L2, 3, 4, they form the femoral nerve. And then you have L4, L5, S1, S2, S3, which combine their anterior and posterior roots. So the posterior divisions, they form, they both form the sciatic nerve, and the tibial nerve is formed by the anterior division, and the common tibial is formed by the posterior division of the roots. So and below that you have S2, S3, S4, they form the pudendal nerve. So those are the, so if you're doing an XLIF procedure or something like that, and the surgeon's coming from more lateral side, you can say that genitofemoral nerve is the most common nerve at risk because it's most outside, followed by the femoral nerve, and then tibial, peroneal nerve, and tibial nerve is the least risk nerve in these surgeries. So practice, this is just a picture of, again, the pathway. You have stimulation site for median nerve. It enters the dorsal columns from C5 to T1. It travels up dorsifasciculus cuneatus, make a synapse in nucleus cuneatus, cross over to thalamus, and then somatosensory cortex. So that was the pathway, and now we're going to talk about the generators. So before we talk about the generators, so there are two characters of the signals. One is called propagated response. A propagated response is a response which is produced along the nerve pathway and is not a fixed location. So the signals produced in the SSEP pathway are produced because either there's a junction or there's a change in medium, but those are the fixed responses. But the propagated responses, they're produced along the pathway. You can put the electrode any place on the nerve and you can get a response. The characteristic is they change the latency, because when you move the electrode, you are moving either away from stimulation site or close to stimulation site. That will change the latency, but it's not going to change the amplitude, because every time you change the electrode, you change the distance, but you are still close to the nerve. The second character is known as stationary response. Stationary response means that the response is produced at a fixed location due to synapse or change in medium. Change in medium means nerve is traveling in the muscle and it enters the CSF for the lower SSEP or upper SSEP, or like auditory nerve is traveling in the bone and it enters the CSF in CPA angle. So there's wave 2 and that. So character is, again, they change the amplitude, because when you change the needle location, if you're getting away, you will decrease the amplitude. If you're getting close, you get increase in the amplitude, but no change in the latency. So the latency will not change because the signal is produced at a fixed location. And the other character is the response either can be a near field or it can be a far field response. So response itself is not a near field or far field response, but it's a distance from recording site to the stimulation site. So the response produced close to the generator, if the record is recorded close to generator, is known as near field. The response produced by generator is far from the recording electrode is known as far field response. So any response either can be a far field or near field, depending how far you are from your needle or recording site is from the generator. So when we stimulate upper in upper extremity SSEP, talking about the median nerve or ulnar nerve, when you stimulate, it creates different peaks. The guidelines, ACNS guidelines, they they specifically mention that their minimum recording site, and those recording site are known as obligate components. Obligate components are not the only signals, but those are the minimum signals you must record. And if you record more than that, that's fine, but those are the minimum. So for the upper SSEP, the first record you should have in every SSEP signal is Earth's point. So there's no excuse for not recording. Um, Earth's point is recorded from the brachial plexus. The second is known as N13, and it is recorded from dorsal column or fasciculus cuneatus. Earth's point is about 9 milliseconds. So Earth's point is not the only, also known as N9, but it's not the only response. There are more responses between them. You have P10, you have N11, you have N12, and P10 is created by the brachial plexus. N11 is dorsal root entry zone. N11 to N12 is when the spinal cord signal traveling in spinal cord. N12 and N13 is a fasciculus gracilis. But 10, 11, 12, they are not obligate peaks. But you can monitor if you put the electrode close to the spinal cord, you will get more 11 and 12 responses. P14 is caudal medial lemniscus, which is at the crossover to the upper side. And then you have 16, P16, which is not an obligate peak, but there's a peak there. And then you have N18, which is recorded from the brainstem and thalamus. And after that, the next obligate peak is N20, which is primary somatosensory cortex. After N20, you have P25, P30, P30, N35, P40, but those are not the obligate peaks. For lower SSEP, we also have obligate peaks. Number one is popliteal fossa, which is about 9 milliseconds, followed by the lumbar potential. Lumbar potential is the response which is produced when the signal enters the spinal cord, and it's a recording from dorsal fasciculus gracilis. P31 is the next, is recorded from caudal medial lemniscus. N34 is thalamic response for lower SSEP, and P37 is from the primary motor sensory cortex. So those are 5 obligate peaks for lower SSEP, but these are not the only peaks. So you have N45, you have P60, and other peaks, but these are the only obligate peaks. So these are the minimum peaks we should always record. So the neural generators for the median nerve, so looking at this table, so you have N9 response, the generator is brachial plexus, the location is Earth's point, and it's a near field response, and it's a propagated response. It's a near field because the electrode is right on the brachial plexus. It's a propagated because there's no synapse, and it is traveling. P10 is a brachial plexus, from Earth's point, it's a near field propagated response, and 11 is coming from a nerve root. It's a location that's near close to the spine. It's a near field and propagated response. So going to 13, nucleus cuneatus cervical response, and now it's a far field response. And 13 also have 13A and B, but for generally we say 13 is a far field stationary response because it's produced by synapse and nucleus cuneatus. P14 is a medial lemniscus response. It's recorded from cervical electrode. It's a far field record because the electrode is C5, but it is too far from the brainstem, and it is a propagated response. The P14 response is a propagated response because the signal is traveling up the pathway. N18 is a response which is produced in thalamus, and it is a far field stationary response. N20 is produced somatosensory cortex. It's a near field stationary. P25, N30, they're all near field stationary responses in upper SSEP. So if you look at the pathway and the peaks, we have median nerve C5T1, ulnar nerve C8T1. So you have brachial plexus response come from the brachial plexus. Earth's point 910 is a near field propagated response. The second recording we do is 1314 for cervical. Those are far field stationary, far field response. P14 is far field propagated response, and N20 and P30, those are for near field stationary responses. So the neural generator for the tibial nerve SSP for lower SSP, you have N9, which is popliteal fossa response, is a propagated response. and it's a near field response. Lumbar potential is the only response in the nervous system which is a combination of propagated and stationary signal. Why is that? Because the lumbar potential, there is no synapse in at the lumbar potential area, lumbar area, but because there's change in the medium, the signal is traveling from the muscle and it enters CSF. There's a click, and it creates a stationary fixed point. And it's also propagated because the signal is traveling along the pathway, and you change the location of electrode, which we typically do. We put electrode in LT12, L1, L2, and T11, and record from all four reference to iliac crest, and you'll see a different propagated signal latency. P31 is a medial lemniscus pathway. It's a fall field stationary response. And 34 is a thalamic response. It's a far field stationary. P37 is a cortical response. It's a far field and stationary. So that's very important to remember, because the cortical response for lower SSEP is a far field response. It's not a near field, because the foot area is deep in the brain. And same when you're looking at the signal, you have cortical signal, transcortical signal, cervical, and lumbar potential. So stimulation sites are important, but sometimes you need a backup stimulation site, because if the patient has peripheral neuropathy, has diabetes or amputation, so anything, or cast or a fracture, so you have to find another site to stimulate. So there are various generators, and the latency is different for different stimulation site. For stimulation, it is important to know, again, same as recording, that impedance of the electrode should be less than 5 kilo ohms, and the ground electrode should always be placed uh, before the first stimulation site. Ground electrodes decrease the stimulation artifact, because when you stimulate, the nerve is activated, but the stray current is traveling on the skin, and it creates a stimulation artifact on all the electrodes, mostly in the Earth's point and brachial plexus. So a big ground plane, a needle is the very bad around. A big disc should be used, because it reduces much better compared to the needle electrode. Sometimes people complain, or they say that they use the disc, the ground pad, but it was worse than needle. And one of the main reason is if you don't scrub the skin well. So because if you scrub the skin well, use abrasive material on a proton 4x4 and rub very hard, so you can decrease the impedance. And because the bigger surface area means less resistance. If you have less surface area, you'll have more resistance to that current. The current, according to SNS guidelines, should be between 100 to 300 microsecond. We use standard 300 microsecond for all upper SSEP. We don't go higher than that. The current stimulation rate is 3 to 5 hertz, anything between, but in odd numbers, uh, to avoid any 60 hertz artifact. So the stimulation file site for the upper SSEP, we have upper SSEP, we do median nerve and do ulnar nerve. We can also do radial nerve. For the lower SSEP, you have more recording stimulation site, posterior tibial nerve for L4 to S3, at medial malleolus at ankle, medial ankle. You can stimulate common peroneal nerve at the head of the fibula. You can stimulate the femoral nerve at the femoral triangle near groin. You can stimulate saphenous nerve at the medial thigh area or medial tibial head. You can stimulate the pudendal nerve at the perineum area. For upper SSEP, for median nerve, the cathode should be 2 centimeter proximal to the wrist crease. So if you see the wrist crease, it should be at least 2 to 3 centimeter proximal to that, and between the tendons of palmaris longus and flexor carpi radialis. Radial bone is more lateral to the thumb, and ulnar is more medial. So flexor carpi radialis is attached to on the radial bone. That's why it's called radialis, and palmaris longus is in the midline on medial to the ulnar. And the anode should be more distal. So anode should be more distal on the crease or close to the crease. So just make sure, so they have at least 2 to 3 centimeter distance between the anode and cathode. So if the distance is less, you'll have less stimulation artifact but smaller signal. If the distance between anode and cathode is more, you'll have a huge signal, will be much bigger because you are stimulating much bigger area, but you'll get a risk of having more stimulation artifact. And the ground should be placed before the forearm or shoulder, but before the other spine, in order to avoid stimulation artifact. For lower tibial SSEP, the cathode should be on the medial border of the Achilles tendon and posterior to the medial malleus, so between the two, and the anode should be placed 2 to 3 centimeter distal to that. Same thing, if you're more for peroneal nerve, you can put on the dorsal surface of the foot, or you can place the electrode on the head of fibula. The head of fibula is posterior to the head of tibia, and the only way you can find that if you bend your knees, and you should practice on yourself before you try on the patient, because it's hard to find. So you have to bend your knee, and you put that your hand below the below your knee joint, and posterior. The anterior one is the head of tibia. You can feel the head of tibia if it had leg stretch or flexed or extended, but if you find the head of fibula with a bend, flex leg, and if you extend your leg, it will disappear under the tendon. So same thing. When you see the patient, you have to ask the patient to bend the leg and find the head of fibula. If the patient have some issues and you want to record more proximal, or the nerves, different nerves at risk, you can do femoral nerve at femoral triangle. Femoral triangle is a triangle which is the upper border is the inguinal ligament, the medial border is the adductor longus, and the lateral border is the sartorius muscle. Between those three areas, the femoral and the important structure is vein, artery, and nerve. So if you have femoral nerve, most lateral, middle one is femoral artery, and the most medial is vein. So you can palpate the femoral artery and then go 1 centimeter lateral, and you can put the electrode. And if you want to put the electrode, you need to use a longer needle electrode, at least 18 millimeter, or for stimulating the femoral triangle. You can also stimulate saphenous nerve at the medial angle of the thigh, or you can stimulate at the medial head of the tibia. So the lateral side is the common peroneal nerve, the medial on the head of fibula. On the medial side, the head of tibia, you can do saphenous. You can do also pudendal SSEP. The pudendal SSEP can be done in male and female. In male, you have to put the anode cathode on the dorsal surface of the penis, and for the female, you have to put inside the labia with a negative cathode in the midline, and I usually put a positive on each side, because sometimes you don't get response from one side, so you have to pick up the other side. So for recording site, again, the impedance should be less than 5. The system band pass recommended is low cut 30 hertz, high cut 3000 hertz. According to the guidelines, that's the maximum the bandwidth, but you can narrow down. The SSEP is usually around 100 to 150 hertz for cortical, and about 1000 for peripheral, and so we do the setup according to that. So the cortical SSEP are produced by gray matter, and the gray matter in the brain, they are dendrites. And also the nuclei of the and which have low frequency signals. So the dendritic signal are low frequency signal. So the band pass of 30 hertz low cut and 500 high cut can give you a good signal without too much smoothing, because if you do less than that, high cut less than 200, 300, you can still get a good signal, but it's too smooth and you'll lose your high frequency signal. So it's recommended not to go less than 500 for high cut, and not to go higher or lower for 30 hertz for low cut. The subcortical and peripheral signals for SSP, they are produced by white matter, which are axon and which are high frequency signal. So a band pass of 30 hertz to 1500 hertz should be used for optimal recording for those signals. The system nomenclature for SSP uses N and P, which is N for negative and P for positive, to designate a polarity of the recorded signal. And that is before it appears on the screen. So N means it's a negative before we start recording. P means it's positive before recording. And every signal has a negative and positive. it depends where we are putting the electrode. So if you put our normal recording side, if we are placing the electrode on negative side, it will be N. But we can also put the electrode on the positive side, and the signal will be upside down or inverted. So that's very important to remember, because we see in normal practice, like very regularly, the electrode is placed on a different location without measuring head, and the signal is upside down, and the person who's monitoring, he's monitoring either a wrong peak, or that can give you a false positive or false negative signal. So once the signal enters the differential amplifier, when you look at the recording setup, so you have active and reference input. The actives is all negatives and positives all positive. So when everything going into active or negative input becomes upside down. So N20 is a negative signal at 20 millisecond, but when it plugged into a negative input or active input of the amplifier, it displays upward on the screen. And the P37 is a positive, it should be up, but because the recording electrode is plugged into negative, it shows negative or downward on the screen. So either you check, you do a inverted setup, or put the electrode reversely, or the signal will be inverted. So if a CZ prime is plugged into a reference input, the P37 will be up on the screen, or CP3 or CP3 or C3 prime, C4 prime is plugged into the reference input instead of active, it will appear downward instead of upward. So the recording side for upper is EPI, EPC. EPI is those terminology are recorded in the guidelines. EPI means earth point ipsilateral to stimulation. Earth point contralateral is EPC. CS5 is cervical below 5. CPI means corticoparietal. C3, which is same as CP3 or C3 prime or C4 prime, which is between C3 prime is between C3 and P3, and C4 prime is between C4 and P4. Low recording side, we have popliteal fossa, distal and proximal. The distal should be 2 centimeters above the crease. So never put in the crease, because if you put in the crease, there's no nerve, and its nerve is splits above that. So you're not going to get a good signal if your electrode is right in the crease. So you have to. So active should be always 2 centimeters above the crease, and the proximal should be 5 centimeters above the distal electrode. So T12 is for recording site for lumbar potential, reference to iliac crest. CS5. Lumbar potential is not necessary for all the cases, but it's necessary, and it must be done for all the XLIF and hip and peripheral cases, because the lumbar potential is not affected by anesthesia, and they're very resistant, and they give you a much better information than other signal. So CS5, CPZ is midline, CPI, CPC are the same electrode. So placing the earth point. So if you're putting the earth point, you have to make sure you look at the most medial attachment of the clavicle and the most distal, and go in the midline. So in the midline and 2 centimeters above, not on the bone, not below the bone, 2 centimeters above the bone. So the electrode point should always be 2 centimeters above the bone, and you get much better. If you're on the bone, you're not going to get, because the bone is not going to conduct any signal. Popliteal fossa, again, you have a crease, so it should be 2 centimeters above, and then 5 centimeters above that, because look at the sciatic nerve, it's split into the tibial and common peroneal above the crease, and if you have to be close to that to get a response. That's a typical for lumbar potential, which is recorded for hip and peripheral cases. We put the electrode on T11, T12, L1, L2, and it's reference to iliac crest, and we turn off 3 channels and record the one where have stationary and propagated signal. They are on top of each other, and the latency of lumbar potential is about 22 milliseconds. CS5, again, figure out palpate C7 vertebra, which is the most prominent vertebra on the neck, and go 2 bodies above for C5. If you go above that, you are going to get much less higher impedance. So somatosensory cortex, again, is a posterior sulcus electrode placement. Need to know the T1020 system, and practicing T1020 10-20 system is very easy. When you do first time, you may take 5-6 minutes, but practicing again and again, I can guarantee you can do in less than 30 seconds. If you practice more and more, within few, like less than 1 hour, you can practice to record, because you don't have to record, measure all the 21 electrodes. So if you look at the surgeons, they know they do the surgeries every day. They do thousands of pedicle screw, but they never put the pedicle screw without measuring, using a navigation or C-arm or something. They use as many techniques as possible to make sure. They never say, I have done this, I put the electrode and I'll just go and put the screw with the, I can tell you. But when we're doing monitoring, when putting the electrode, everyone tells, okay, I've done this monitoring and I can go and put the electrode without measuring that. I can, which is not medically or even ethically correct. So the surgeon is not going to take out the brain tumor. It's saying, okay, I've done this so many times, I can just go. They do navigation for every micrometer and take out the tumor. But when we put, so you put the electrode any place on the brain, you'll get something signal, because signal is produced and you'll be on, but doesn't mean you have the right signal and you're doing. So all you have to do is measure from Nasian to Indian, go to midline, and then A1, A2, go to midline. That's your true CZ. And if you get 2 centimeter back and 2 centimeter back, you have CPC. So yeah, so you have to measure all those 4 electrodes. And once you have 4 electrodes, you're all set. And C3, C4 is used for motor evoked potential. For SSEP, you can get signal wherever you put the electrode, but motor, if you're not on the gyrus, you will not. You have to stimulate very high, and if you're not at the right place, you stimulate very high, and the patient moves and jump, and at the end, surgeon will tell you don't stimulate because your patient is jumping too much. So head measurement per international 1020 system is the most important step for recording the reliable SSEP. Always keep a measurement plate in a backup. With practice, you can measure the head within actually within 30 seconds, and all you have to measure is C3, C4, and then and CZ prime and CP3, CP4. They are 2 centimeter behind C3, C4, and FPZ is 6 centimeter, and T to CPZ. So here are those points. So you can just and also keep a marker. So you can put just a small points, 4 points on the in the pre-op area. So parameter for software, the gain and sensitivity. The gain and sensitivity is the screen sensitivity, which should be about 1 to 5 microvolt, ideally for upper and lower. Low cut filter should be 30 hertz for both upper and lower. High cut for cortical is 500. High cut for subcortical and peripheral is 1500 hertz. The sweep, it should be, I need to fix this, is 50 millisecond for upper extremity and 50 millisecond for lower. So it's a microsecond, but this is 50 millisecond. It should be 50 millisecond for upper and 50 millisecond for lower. The stimulation and intensity should be about 15 to 25 milliampere. So if you're doing stimulation median now, you can go higher to 30, 35, but ulnar you should never go above 20, 25. Lower you can go up to 100 milliampere without any problem of any damage. You can go as low as 40 or 35 for pediatric and infant, but you can go up to 100 milliampere without any. The stimulation duration should be for 300 microsecond. Stimulate, the ideal is between 2.66 to 4.79, and minimum sweep should be about 200 million. So the following peak latency and so you have peak signals, and we talk about the obligate peak. Now we have peak and interpeak latency. So we have obligate peaks, and the important part to remember is interpeak latency from Earth's point to P14, which is known as peripheral conduction time, and P14 to N20, which is known as central conduction time. Peripheral, if there's a change from EP to Earth's point to P14, that means something is problem outside the spinal cord. If P14 to N20 or CCT is affected, that means brainstem or spinal cord is affected. For the lower, same thing, all 5 obligate peaks from the popliteal fossa to lumbar potential is a peripheral conduction time, and lumbar potential to P37 is central conduction time. So that's a recommendation from the ACNS. So we look for morphology and amplitude and latency. Latency is from stimulation side to first deflection, and amplitude is from peak to peak. It has been used that 50% decrease in amplitude and 10% increase in latency is an alert. So when the first meeting happened in 1978, the group of people, they came together. They said they wanted to have a criteria, and they set that criteria, but it was not based on any clinical literature or any studies. So it was randomly selected. So don't wait for 50% drop. So you have 40% sudden drop or 35% drop. You need to know there's something going on. So you cannot just sit down and wait that once you cross 50%, then you're going to alert the surgeon. So if there are any sudden changes, um, you should investigate those. So for the result analysis, we look at the Earth point, P14, N20, Earth point to N20, Earth point to P14, and P14 to N20. So look at the obligate peaks and interpeak latency. And the criteria according to the guidelines, there are two. You look at absence of obligate peaks, so if they're absent, or there's prolongation of interpeak latency. Most of the time, I don't know, most of people, they don't look at interpeak latency, but the interpeak latency is one of the key factor for abnormality. Same for uppers and lowers, obligate peaks, delay and change in interpeak latency between for peripheral conduction time and central conduction time. The anesthesia again has to be educated for better recording, and why we care about, because it's affecting our signal, and amplitude and latency of cortical signals are affected by volatile agent most than any other. And the reason is that they affect the synapses, and the gases CO, decibel, isovalent nitrous oxide, they go and block the synapse. And the cortical signal recording site have more synapses than subcortical, which is only one synapse, and peripheral has no recordings, no synapse. So the corticals are affected more. Subcortical is the last one, and peripheral they don't they are not affected by, unless you have very high anesthesia. If you have very high anesthesia, it causes slow sodium potassium pump. That's indirectly affecting peripheral responses. Beside a regular anesthetic agent, the other factor we always look for and monitor is carbon dioxide level, because carbon dioxide level causes changes in blood flow. If you have a hypocapnia, which is decreased carbon dioxide, less than 25 millimeter, will cause loss of your SSEP. So every anesthesia machine has CO2 level, always measure the CO2 level. Anything below 25 millimeter, you lose your SSEP or MEP. Anything above 40 milliampere also affect your SSEP. This is a hypercapnia, because hypocapnia, which is below low carbon dioxide, is going to cause vasoconstriction, and is typically done intentionally for decrease the blood loss in craniotomies and cranial surgery, which causes decreased blood flow, and it's going to cause loss of signals. Hypercapnia, on the other side, causes vasodilation. The blood flow will dilate, and if the blood flow is dilated, if you're doing especially MEP, the current will shunt to the blood vessels, and it's not going to activate the motor cortex. Intracranial pressure also affect your MEP. Higher ICP, 10 and below is normal. If you have 10 more, 50, 100, but ICP is not monitored in every typical anesthesia machine. They always have a separate machine for that. Look for the electrolyte balance, changes in hypomagnesemia, hypokalemia, low potassium, low sodium level, loss because of the blood loss, and these factors, they affect and calcium level also, they affect your SSEP and signals, because they affect your sodium potassium pump. And you have decrease in sodium or potassium or calcium, which are the calcium gates, which will affect. So many times you have no change on anesthesia level and no blood mean out pressure, but you still affected, signals affected. So these are the other issues that can cause you changes. So every signal has a dipole. Dipole means two poles. So when signal is produced in body, it has a negative side and a positive side. So depending where you put the electrode, you have a negative or positive. So N20 is produced above on the surface of the skin of the scab. So if you put a deep electrode inside brainstem, you will be on the positive side. So N20 will be inverted. But N20 has a, if you put same thing electrode anterior to the central sulcus, it will be inverted. So yeah, it will phase reversal. So that's why you need to know that where you put the electrode, and if you're looking for up peak and you are monitoring the first up peak, it may not be the N20, it may be N18. So again, just a sample data for medial nerve SSP. We have cortical, transcortical, subcortical, medial nerve response. So in this signal, you can see you have the blue one is the N20 on left side and right side. The red one is P25. P25 does not change the polarity, and the green one, the trough is and the P30. The second is transcortical same signal, and the channel 3 is from C4 to left earth point. On the left side, C3 to earth point is recording a thalamic response. The up peak, the down peak is P16, and up peak is N18. Posterior tibial nerve SSP, same thing you're used to. Peroneal nerve SSP, if you're stimulating for dorsal surface of the foot, you can do post-popliteal fossa. But if you're stimulating from the head of fibula, you don't get popliteal fossa. You can record the lumbar potential, but will not be. The latency will be shorter, 10 milliseconds. Femoral SSEP, so you can stimulate femoral triangle. Always look at the latency, because you are about 15-20 millisecond closer to the recording site. So typical signal recording SSP in adult is about 20-25 millisecond, 20 to 25 millisecond downward peak instead of 30p37. Saphenous is almost same depending on the patient, but you have about 32 millisecond. Pudendal nerve SSEP, the typical peak is P30 and N38. The P30 is downward peak, and the pudendal nerve SSEP is by stimulating the perineal area. Sensory mapping is again we talk about monitoring using the SSEP and for function, blood flow and area localization and central circular localization in the brain stem, for the blood flow and the structure for the brain stem and the spinal cord. So this picture is showing you the grid. They have 8 contacts, 1, 2, 3, 4 on the left side and 5, 6, 7 on the right side, which one of the surgery we did like few weeks ago. The surgeon is placing the grid, you can see on the monitor, and on the left side is we have color MRI, and it is known as DTI or diffuse tensor imaging, which is a tectography. It shows the fibers, the white matter tract imaging, the blue fibers, these are all motor fibers. So the motor fibers running from cortex to the spinal corticospinal tract, they are colored in blue. The fibers which are connecting the left and right hemisphere, they are in orange color, and the one which connect the anterior and posterior, they are in green color. On the right side in the left picture, you can see the tumor under the blue area, and we have a monitoring machine on the. So if you put the grid on the brain, again, place depending on where the grid is. So we stimulate the SSP, and the signal is produced in post-central gyrus. So if you have like this picture, you have 4 grids. G1 is first, grade 2, grade 3. It doesn't matter which direction is. We can still tell the surgeon. So the SSP should be up and down. So, but on grade 1, you can see the signal is down and up. On the grade 2 is up and down, and 3. So the central circus is between 1 and 2, where 1 is pre-central and 2, 3, 4 are post-central. The N20 is the peak for the upper SSEP. The amplitude is much higher. So amplitude could be in 50 to 80 microvolts compared to 1 to 5 microvolt in scalp SSEP. And the peak for the pre-central peak is about 2 millisecond delayed, and those known as P22. So the P22 peak typically is the downward peak. So that peak can be recorded on the regular spine cases. If you put the electrode anterior to the central sulcus, you'll get a P22 instead of N20. On the right side, we call it on-axis mapping. Left side is off-axis. On-axis is when you get this P25 peak on top of that. That means that you are right on the central sulcus. If you don't get P25, you are not in the hand area. You are on the central sulcus, but not in the hand area. That's one of the first paper published about technique for recording the triphasic peak, which is 20, 25, 30 complex. Again, you can see the grid on the green is N20 and black is P30 and red peaks are P25. So the signal is produced in two dipoles. One is tangent to the surface. The tangent to surface produce 20 and 30, which is anterior, first front and back, anterior, posterior. Radial is toward the scap, which produce P25. So P25 doesn't change the polarity because you go anterior, posterior, it will still remain the same. Again, another use of somatosensory cortex, we have 2x4 grid, grade 1, 2, 3, 4 on the right side, 5, 6, 7 on the left side. You can see the grade 1 is down and up, so it's a precentral. 2, 3, and 4, they are up and down, they're post-central. On the left side, 5 is down and up with P25, and 6 is up and down, 7 is up and down. So 5 and 6, they have P25, so that means 5, 6 are much closer to the, and they're bigger in amplitude than 1 and 2. So the central circus is between 1 and 2 and 5 and 6, with 5, 6 more close to the hand area. We can also do phase reversal for lower SSEP. You can this is a signal from tibial nerve stimulation, but when you do tibial nerve stimulation, you don't get phase reversal all the time. So most of the time, you get only up and down peak. If you look at this peak, all the signals, they are up and down, which is opposite to the P37, which we see on the screen, which is down and up. And one of the reason is when you do tibial nerve SSEP, so you do record from CZ, FPZ, but you also do transcranial recording, which is left and right side. So when you stimulate the left tibial nerve, the signal is produced from the right cortex, but the direction of the signal is toward the left side. So for left side, left tibial, you should always record from the left cortex or C3 prime. For the right tibial, you should always record from the C4 prime. The signal is produced on other side, but is recorded. The dipole is so. So this one is stimulation the left tibial nerve and recording from the right cortex. So this signal is produced from the right cortex, but the electrode is on the opposite end of the dipole. So the P30, which is actually not, it is on N37, which is the opposite end of the P37. So that's why the peaks are always up and down if you're recording direct from the central circuit. If you have brachial plexus mapping, again, you can stimulate each root on the nerve. So this picture, this is one of the cases I did with the brachial plexus. Patient have a deltoid shoulder injury, brachial plexus lateral cord was damaged, and the deltoid was not able to use deltoid biceps. So we identified the flexor ulnar nerve and took one of the fascicle and bypass to the C5 root and flap in here. So you can stimulate each root and stimulate and record the SSEP from cortex and sensory cortex and subcortical responses. Another case, so all the cases, like this is one of the worst cases I did, unfortunately, but patient have severe kyphosis and all the structure at risk. So this patient has a very good baseline, but they were affected due to surgery. Trauma, thoracic trauma, spinal hip trauma, so the sensory signals are affected. So we are going to talk about motor signals separately. There's no one test you can do and say that everything is perfect and you can monitor the patient. So you have to do a better multimodality monitoring. So neck trauma. So I just want to show you the surgical event. So anesthesia, on the left side, you can see anesthesia. Your left and right corticals, and transcortical and cervical. You can see the top signal is 10:33 a.m. And going down, getting later, and you can see drop and slow decrease in amplitude because of anesthesia. On the right side, you can see cortical, cervical, and then cortical left and right cortical. So you can see the change due to cooling and of the body, and there was a traction, and surgeon was informed, and he removed the retractor. The temperature was increased, and signal came back. So it was within less than 6 minutes the total time. But if we have not informed the surgeon, there could have been permanent damage. So So the gray matter is sensitive up to 2 to 4 minutes. So if less than 2 minutes, you see the changes. After 4 minutes, they are permanent damage. But in white matter track, if the change ischemia to the white matter track can resist up to 11 to 20 minutes. But the gray matter, it doesn't. It's less than 2 to 4 minutes. More than 2 to 4 minutes, it will be permanent damage. So the other factor that will affect your signal, you need to keep an eye on is compromised blood flow to the extremity, peripheral ischemia, blood clot, BP cuff, positioning of the extremity, even upper and lower, IV infiltration. So if there's an IV fluid going into subdermal, it accumulates in the limbs and it blocks the signal. Hypothermia, scap edema. So patient has scap edema, it will cause brain shift, or needle will be more away from the recording side, so you'll have loss of signals. Failure of stimulation, failure of recording, external artifacts, CO2, hypocapnia, hypercapnia, and ICP. So again, in summary, remember the post-sensory pathway, you should be able to draw them without looking at the picture. Remember the generators and recordings and all the sites. So if you go to more complicated set, and we're hoping that we are going to do more and more complicated cases, so you'll be able to do a better. So if you have an P16 but N18 is gone, you can specifically tell the surgeon, my thalamus is okay, but thalamocortical radiation have a stroke, so something like that. And keep your notes and remember everything. I'm sorry I took longer than that, but SSP is a topic that I can talk about for the whole week, and it's very difficult to summarize in 1 week. 1 hour. You can ask anyone has a question. You guys have any questions?
No, sir. Thank you very much.
Okay, thank you. Okay, have a good evening, everyone, and thank you for listening to this. Good night.